Okay. Okay. The least frequent topic that we like to talk about is our failures and complications. But I believe that these are the most things that make us learn more about the surgeries and learn and improve our practice. So we're going to speak about how to avoid failures in MPFL reconstruction surgeries. I have nothing to disclose. And we shall discuss, first of all, the failure rates in MPFL reconstruction surgeries and how to define failure and how the failure process starts and how it goes and continues. And I combined the causes and how to avoid them in order to know how to avoid the surgery and have higher rate of success. And finally, how to manage a case of a failed MPFL reconstruction. So the backgrounds, definitely MPFL reconstruction is gaining more popularity through the years. And recently, since 2007, it has the rate of MPFL surgeries has increased all over the world. And that's because they have excellent short to mid-term results all through these years. And this is where we were in 25 years ago, starting 2007, the era of MPFL surgery, and definitely it has something to do with the discovery or the publication of shuttle, where it made our surgery easier, and then the era started from 2008, and here we are. Up till 2017, the rate of MPFL surgeries is increasing. But as long as the rate of the surgery is increasing, the complication and failures increase as well. And we expect in the upcoming years, the rate of revision surgeries will increase as well. So the failure rates in literature. What does the literature say about the failure rates? Here is a case series reporting that the overall rate is 13%. We will find discrepancy in the recent literature about the complication and failure rate, and it starts from 2016, and every year more and more authors are reporting about failures of the MPFL surgeries. So it's a case series in 179 knees, and it reports that the overall rate of failure or complication is up to 13%. And interestingly, they report that 50% of these failures are because of technical errors. A later systematic review telling us that the rate is 26%, and they had a problem about how to define clinical failure, and they gave us an insight that we better define clinical failure versus the success only based on some scores, clinical and radiographic and patient-reported outcomes. And the most recent systematic review only reports 3%, but it only reports, we have to be cautious while we're reading the literature and analyzing the literature, because they only reports about short-term results, and the only parameter they define failure with is reoperation. So how to define failure? What do you think? I'd like to take your opinion. How to define failure of a case of MPFL? Anyone has suggestions? Recurrent instability or recurrent dislocation. What else?
Stiffness.
Stiffness, pain. Okay, persistent pain. Any other options? Yes? So it's a reoperation or a need for reoperation. So do we really have one parameter to ask for? Let me say that, as you said, some describe subluxation as a failure, and a redislocation as a failure. A positive apprehension sometimes in some studies are defined as failures. Ongoing pain, as you said. Suboptimal surgery's outcome, like the stiffness Dr. Abnour just said, and the reoperation rate. So what is actually the failure? To me, it is simply the recurring signs and symptoms of instability. So we will have to revisit first, what are the signs of instability? We have to remember that it starts with malalignment, proceeds to maltracking, and it presents with either pain, subluxation, or dislocation. So either one of them is a sign of instability or a recurring sign of instability. So to define failure is simply recurring symptoms and signs of instability back again as it started. So we have to think thoroughly how to reduce our failures. But first, what leads to failure? You have to understand the biomechanics behind that. So the strain on the reconstructed ligament it cannot withstand it, our graft cannot withstand it, so the graft either stretches or tears and it fails to perform its function. So either stretching of the graft or it tears again, it fails to perform its function. So why does it fail? Why can we have increased strains on our graft until it fails? And how can we avoid it? And I combined both together. Causes of failure. Everyone tells me one cause of failure he might think of, or the most common he thinks of. Dr. Muhammad. Over tightening, Dr. Meher. Not normal fixation point, misplacement of the tunnels. Bad alignment before the surgery. What else? Do you think of any other thing? Persistent lateralizing force. Oh, this is deep. Okay, persistent lateralizing force, and this is very smart. It sums up everything. Persistent lateralizing force. Okay. We can name a lot of problems or causes. I can say that I chose the wrong patient to do the surgery, or I had the wrong indication to reconstruct the MPFL. I might be missing a risk factor and missing what is the real cause of the lateralizing force. So a lot of causes, but we can categorize them into either a failure in my decision, or a failure in my technique. So either I chose the wrong patient or miss some risk factor, or I did an unnecessary surgery for the patient. So it is a wrong decision, or the decision was right, the patient was a candidate for MPFL surgery, but I did my surgery not in the right way, as you just said, non-anatomical tunnel placement, improper tensioning, or operative complications. So we'll begin with the wrong patient and the wrong indication. Sometimes we see that the MPFL, because it's now getting easier for the surgeons to do, it is described and actually operated for anterior knee pain. And Dr. Muhammad Raha in the first presentation clearly said that it should never be equated with anterior knee pain. If you still have the diagnosis of anterior knee pain in mind, you do not consider surgery. You need to know what is the cause of anterior knee pain. It is described for the patellar instability, and not any patellar instability. The ideal indication is at least 2 episodes of patellar dislocation. This is the ideal indication for MPFL surgery. So we shouldn't operate on a patient that did not dislocate at least twice. And this is what the literature says. Okay, this is a case example of a fixed lateral dislocation, and the dislocation is in knee flexion above 40 degrees of knee flexion. So if I did an MPFL surgery alone for this patient, it would be a malpractice. So the problem is that this patient had a long time of fixed lateral patellar dislocation in knee flexion. So he has a shortened extensor retinaculum, a shortened or contracted lateral structures. So I have to start with lengthening of the rectus, lengthening of the lateral retinaculum before I might not even consider doing an MPFL at the end. So this is how we think of each case. So avoid failure by make sure that the patient suffers from MPFL insufficiency first. Second, missing, and I believe that this is what Dr. Meher and Dr. Ahmed said, missing the risk factor. Improper assessment of patellar instability before the surgery dooms your surgery to failure, or at least it will not succeed in satisfying your patient. So either I can miss a trochlear dysplasia, or I miss a patella alta, or I can miss an increased or a rotational problem with an increased TTTG distance without addressing it, because MPFL surgery is the easier one. So if I do an isolated MPFL surgery with either one of these, I might have a problem. And all the literature says that trochlear dysplasia is the most important predictive risk of failure of your MPFL reconstruction, and especially if it is accompanied with the J sign. So not a radiological parameter, not only trochlear dysplasia or even severe trochlear dysplasia, but any trochlear dysplasia with a J sign is a predictive risk of failure. Literature has discrepancy in defining what is the index of the Caton-Deschamps index that might necessitate distalization of the tibial tuberosity. But one report included that above 1.3 CDI is a the second most common predictive risk of failure. And definitely above 20 in the TTG distance, we had a trend towards worse outcomes. So avoid failure by clinical examination of your patient. Don't depend only on radiology. A J sign with trochlear dysplasia doomed this patient to fail, so you need to address the trochlear dysplasia before attempting to reconstruct your MPFL. Definitely there is a trend now towards MRI in diagnosis that tells us a lot about the functional engagement, the relation between each person, each cartilage surface and the other. So the plain X-rays only tells us about static views and indexes and numbers, but it does not tell us idea about how much these cartilage meet and in what degree of knee flexion. So the MRI now is exploited more to know in trochlear dysplasia about the articular cartilage geometry and congruence, patellar height even, and they study the functional engagement before defining. It's not just the CDI that tells us whether to distalize or not the TT, but it's about the functional engagement. When at this patient, at what degree does the patella engage in the trochlea? And lastly, they now talk about the TT PCL distance, which is a more accurate way to assess rotation and without affected by the trochlear shape, like the TTG distance. So the third cause of failure in my decision is doing an unneeded adjunct surgery like the lateral release, which is the most famous and the most commonly used, and I hope that it's getting less and less every day. So excessive lateral release might lead to iatrogenic medial instability or even multidirectional patellar instability, and it shall never be routinely used with MPFL surgeries. You have to avoid this failure by individualizing your approach using the a la carte, and never do an unneeded surgery. It might do more harm than good. And if you need it, if there is definite contracture at the lateral retinaculum, consider lengthening more than you consider the release. So getting to our failures in the technique, non-anatomical placement, this is the most common and frequent and significant technical mistake that leads to failure. Malposition of 5 millimeter causes severe significant redistribution of forces, and definitely a decline in the WOMAC and the KOOS scores. Definitely precisely locating the right point for an femoral tunnel is the most important part, technical part in our surgery, and it leads to severe chondropathy and long-term osteoarthritis if not taken care of. Avoid failure by obtaining a true lateral radiograph during the surgery and knowing your anatomy, and even if you need to do an incision, and follow the landmarks in order to precisely locate, and don't only depend on your radiograph or intraoperative imaging. Sometimes we face this, a failed or a complicated fixation, and the most common cause is the patellar fracture. Yes, the rates are low, but it is a serious complication, and we have to deal with it as we go. So avoid failure by using techniques like avoiding going all through the width of the patella and using suture anchors in order to avoid these complications. Lastly, the improper tensioning, and this is a very important surgery. This is an important point. Despite that the literature did not say that it causes failure or re-tear or reoperation, it did not correlate the improper tensioning with this, but it definitely has to do with this. And always remember that MPFL is never tensioned, it only guides the patella. So it's like the dog leash. The dog leash is always relaxed and not tensioned except in a certain point to prevent it going through the wrong side. So you shall fix your MPFL with no tension. Don't pull at all, because it might cause post-operative pain and decreased flexion, and this might lead the graft to fail with high patellofemoral pressure that definitely will end in osteoarthritis. Avoid excessive tensioning. Fix in 30 to 45 degrees. Never pull. Check if the graft tension rises intraoperatively before you fix. So the most two important landmarks for or risk factors for failure is a failure in the decision by improperly assessing the predisposing factor for patellar instability and a non-anatomical tunnel placement. How to manage failure: to properly assess the patient and revise the first decision taking and improve your technique. Properly assess by reassessing other instability factors, and consider dynamic assessment all the time in your radiographs. If you didn't do it for the first time, do it in your revision surgery and carefully locate your old insertion points. Revise the decision. First, if MPFL was indicated in the first place, and if it is indicated, if it needed an adjunct procedure to accompany. ممكن بس one more minute, please. So you have to revise the first decision if it is indicated, and if it was indicated solely or it needed an adjunct surgery. And thirdly, to never do an unneeded surgery never do an unneeded surgery. Improving your technique by choosing the graft for the second time and choosing your fixation method. And it's wise to think of at another level in order not to fail again. Adjust your tension this time, precisely locate your anatomy, and put the old surgery in mind, the old tunnels in mind, the old fixation techniques in mind, and be aware of the dilated and old tunnels. To conclude, failures are not just redislocations, they are not just reoperations. Any signs of recurring instability is a failure. Second, reported failure rates are not high still, but it is increasing with time. Predictive risk factors, the most famous and common predictive risk factors for failure are trochlear dysplasia with the J sign and Caton-Deschamps index more than 1.3. Pay attention to the predisposing factors, and you have to dynamically assess in different degrees of knee flexion the position of the patella. And I think this sums it all. And if you are dealing with a revision surgery, take care of, think differently at another level and think wisely this time. I believe that this would pave the road to succeed. I think this is all. Avoid femoral tunnel misplacement and think differently and thoroughly before your revision. Thank you very much.